You've been looking at comprehensive genomic profiling, in particular in bladder cancer. Can you tell me what are the big issues that you were trying to look into by looking at genomic profiling?
That bladder cancer, unlike lung cancer, for example, did not have a single targeted therapy available for it. And that if we searched for targeted therapy possibilities in bladder cancer by doing comprehensive genomic profiling, we might be surprised that this disease could have a chance to benefit from this new type of approach rather than the standard chemotherapy-only approach. That was our hypothesis, that those targets were there, they just had not been searched for in a broad and comprehensive way before, and we wanted to do that to see if we could help patients with bladder cancer.
Could you tell me about the study then, what exactly you did?
So we received samples from 295 patients with metastatic bladder cancer. From those samples, we extracted and sequenced the tumor cell DNA and then analyzed it to search for therapy targets for drugs that were either on the market or available to patients in mechanism-driven clinical trials.
And what did you find?
We found an extraordinary high percentage of patients had genomic alterations, and that these were important ones that could get the patients onto targeted therapies. And then we looked and tried to find as many patients as we could that had actually had their therapy changed and targeted agents attempted. And then we presented this morning examples of several patients who did go on targeted therapies and are showing partial or major responses to the new targeted therapies they're on.
Could you give me some examples of how the genomic alterations guided your therapy?
Sure. Several patients had alterations in a gene called HER2. It's so well known for breast cancer and upper GI tract cancer. But they didn't just have HER2 amplification, which is the test that's traditionally searched for in breast and upper GI cancer. They also had mutations, or we call them base substitutions, in the HER2 gene sequence that you would not find by those classic day in, day out tests. And patients who have HER2 mutations in bladder cancer, they appear to respond to the anti-HER2 therapies, although a major trial of HER2 mutated bladder cancer has not been conducted to date.
Of course, there were other genomic alterations and other suggested or therapies that could now be considered. Overall, what do you think was the impact of looking for these genomic alterations and finding them?
The impact, I think, is that the incidence of alterations that could be targeted was higher than expected. And particularly the fibroblast growth factor receptor 3, FGFR3, was altered in the high percentage of patients, more than 20% of the patients, as close to 30% of the patients, and drugs that are targeting the FGFR3 are effective in bladder cancer, and possibly combined with another series of drugs called the mTOR inhibitors. And there are examples of extraordinary response in bladder cancer to patients treated with the combination of pazopanib, an anti-FGFR drug, and everolimus, an mTOR inhibitor.
And you wouldn't have known that you could use those drugs if you hadn't found the GAs.
The extraordinary responders were given the drugs with no knowledge that the tumors had an FGFR3 alteration. Now, as we look back on them, we see that they did, so that those were targeted therapies blinded to the target when they were tried. But now we'll see, I think, trials emerge to treat all the bladder cancers that are metastatic with FGFR-driven disease with this combination, and I think we're going to see dramatic improvement.
Right, taking this forward then, would you like to give busy cancer doctors a glimpse of how you think this could be applied?
I think it's a sea change in the management of this disease. Instead of the classic, probably we use neoadjuvant platinum-based chemotherapy prior to cystectomy, and then platinum again if the patients relapse and develop metastatic disease. We'll first want to know the DNA sequence of the tumor before we keep piling on the damaging and toxic routine drugs, that we have a patient who has a chance to benefit from a targeted therapy rather than an untargeted therapy.
So are you saying that the cancer could be targeted in a more individualized way?
This is precision medicine for bladder cancer, absolutely yes.
So the bottom line message in terms of how this could improve therapy is what?
is that each patient will get a customized treatment designed for them alone and not be treated as a group of patients with metastatic bladder cancer in which they get the same chemotherapy on the front line and then the next chemotherapy on the second line and the next. Instead, right from the beginning, if they develop metastatic disease, they get their tumor sequenced and then a custom treatment is designed for them and them only.